Great. So good morning, and thanks to everyone for inviting me to speak to you all today. When I was initially invited to speak almost a year ago now, pre-COVID-19 pandemic, and it seems so long ago, I was planning to talk about ending the HIV epidemic in the U.S., to talk about some of the structural drivers of HIV infection and the importance of achieving health equity, which is what my work is focused in on. Given the urgency of the COVID-19 pandemic, the extreme racial and ethnic disparities that have been noted here in the U.S., as well as some of the parallels in terms of structural drivers and inequity with the HIV epidemic, I'm going to focus most of this talk on COVID-19. So I'm going to start by presenting the COVID-19 data that we have currently available by race and ethnicity. Unfortunately, much of that data is woefully incomplete, and I'll talk about why that is the case and the problems that creates. But nonetheless, the data that we have from state departments of health and from the CDC really paint a very dire picture of the toll that COVID-19 is having on Black and Latinx individuals in particular. Then I'm going to turn to the presumed drivers or root causes of these disparities and talk about structural inequity and some of the parallels with HIV infection. And though I'm going to spend most of this talk being descriptive, so telling you kind of the lay of the land and what we know right now and highlighting the disparities, I would like to spend some time at the end of the talk talking about actionable solutions. I think that's what we as healthcare providers and researchers want to know. I mean, we want to know how to go beyond this period of emergency to sort of create sustainable change. So that's sort of where we'll end up by the end of the lecture. So let's start with a review of the timeline of COVID-19 in the U.S., and this is very abbreviated, obviously. So January 20th, there was the first confirmed case in Washington State. On February 28th, we thought that was the first death, but retrospectively, it's clear that the virus had been circulating before then, and there were deaths that preceded that. By March 17th, COVID-19 cases were present in all 50 states, and by March 20th, New York City was declared as sort of the outbreak epicenter. So we saw the devastating impact that COVID-19 had on populations within New York City. So around this time, we really didn't have data on race and ethnicity in regards to cases or mortality, but there was quite a bit of buzz going on, quite frankly, within circles of people who do racial and ethnic disparities. A lot of the thought leaders said in a very foreboding tone that this is going to have a devastating impact on communities of color. And certainly within social media, it was counterintuitive, actually, because there was quite a bit out there saying that, well, maybe Black people, particularly this is about Black people, were immune to COVID-19. And that really just came from the fact that there was no data. But then at the same time, a lot of folks who were kind of in the know and kind of aware of the fact that, this is something that is going to cause a lot of problems were obviously quite worried. So by March 26th, the U.S. really took over the lead in terms of the number of COVID-19 cases. But it really wasn't until the first week of April, so that first full week of April, where we noted that there was data available by race and ethnicity. It began to be released in certain jurisdictions and states, and it was quite sobering. And probably the most extreme disparities, or one of the most extreme disparities, was noted in Louisiana. And that's where we saw that 70% of coronavirus deaths were among African Americans or Black individuals living in the U.S., despite Black individuals being 33% of the population. So this was striking and shocking to some people, though, like I said, there were people who sort of in the know, who understand, dynamics of infections like this, and the fact that Black and Latinx individuals are at risk for many of the reasons that we'll talk about, but still quite striking and shocking to people. So soon after that, or actually around the same time, began to be released from other places, particularly here or I shouldn't say here, I'm actually from Chicago, that's why I said here. In Chicago, it was noted that 72% of the deaths from COVID-19 complications were among Black individuals, 52% of the positive tests for coronavirus were among Black individuals, and Black individuals really only made up 30% of the city's population. So again, striking data, clearly there's a problem and clearly something needed to be done. Data from a number of other states began to trickle in over time. Across the top of the slide, you see some southern states. I already talked about Louisiana, but certainly we've seen similar data. This is early on in Georgia. Things have become more clear, and there's greater disparity in Georgia also, as well as in Mississippi. Most recently in Georgia, there was a small study that came out looking at a number of hospitals around the Atlanta area, showing that 80% of hospitalized COVID-19 patients were African American or Black individuals. And also, I talked about Chicago, but looking at overall, the overall state of Illinois, clear disparities, 14% of the population being Black and 42% of the deaths being amongst Black individuals, similar to the data that had been noted in Michigan. So it was actually data from New York City that began to emerge to show increased mortality amongst the Latinx population. And when New York City released its data on COVID-19 in terms of mortality, what was noted was quite disturbing, but this wasn't so surprising, again, because of the diversity within the New York City population and what we had sort of seen over time. If you look at this data, you see 22.8 cases per 100,000 population were noted amongst Hispanic individuals, and that's twice as high amongst white individuals. And close behind that are the number of cases amongst Black individuals. So here at home, the media began to highlight disparities before the data was actually available. And this particular article came out in the Boston Globe describing the increase in Black, in Black and Latinx patients with COVID-19. And what this article actually focused in on was the fact that there were an increased number of cases of Latinx individuals who were presenting for care with COVID-19 to East Boston and Lawrence healthcare centers, which are the two largest healthcare centers in and around Boston. And also at MGH, you know, clearly there's something going on, even though we didn't have the data quite yet. So these maps came out soon after some of this inkling from the media, and I think a lot of it was pressure to release more data about what's happening in terms of the epidemic. If you look at these maps from the Boston Public Health Commission, on the left, you see Boston City broken down by neighborhood, and what you're looking at is the COVID-19 rate within each neighborhood, and the darker purple areas have higher rates than the rest of the city population. And you see higher rates in Mattapan, Hyde Park, Dorchester, and East Boston. And if you look to the right of your screen, you see that those are neighborhoods that have higher rates of Black and Latino populations. And on top of that, I mean, I think this type of mapping is very helpful because it gives you a sense of the structural issues, the structural factors that these communities may be facing, because we know that within these neighborhoods, there are higher numbers of immigrant populations, there are problems in regards to housing and overcrowding, and lower wage earners, essential workers, all of these things, these maps were very helpful in sort of pointing that out even before the data was available. So when the Boston Public Health Commission actually released the data, there are two things that I think are important to notice here. First, there 37% of the data in terms of cases by race and ethnicity, it's actually missing. Okay, so we don't really know, you know, who those people are in terms of race or ethnicity. And then if you look at the known cases, it's interesting that 40% of the cases were amongst Black and Latino individuals, and about 25% of Boston is Black, and then about 16.4% were Latinx. And I think most people who looked at this sort of wondered if there was an undercount of cases amongst Latinx individuals based on the unknown or missing data. And that's quite possibly the case. About 20% of Boston City is Latino. So the state level data was released soon after Boston was released, and it's been extremely challenging to interpret. I mean, if you look at these data, if you look at the pie chart to the left of your screen, you have cases by race, ethnicity, and you see in the blue portion of the pie, 53.6% of the cases are unknown or missing in terms of race, ethnicity. In the middle, you have cases reported being hospitalized, 36.9% are missing, and then you have deaths on the far right, and almost 50% are missing. So it's very difficult to understand the magnitude of the problem when you have so much missing data. In my conversations, I have had conversations with folks who are, working very hard, I think, at the Department of Public Health to sort this out. A lot of it is based on what's happening at testing sites, what's happening at clinics in the setting of emergency, and just not getting that data in. And that's not to make an excuse. I think it's very important, but I think it's also kind of it's relevant to understand the overall dynamics of what's happening. So what did the national data look like around that time? Well, honestly, we still don't have great national data. These data were released by the CDC, which basically looked at hospitalizations for confirmed COVID-19 in 14 states, and those 14 states included California and New York, so large states. And they included, this data set included 1,482 individuals. Unfortunately, similar to what we've seen in the other data sets, most of that data is actually missing race and ethnicity identifiers. So it was only 580 cases that they were actually able to look at to see exactly who folks were. And if you look here in the middle, you see that this is the data that's kind of been reported in the media quite frequently, is that 33% of hospitalized cases were among Black individuals, so only 18% of the population of those 14 states was actually non-Hispanic Black. Again, if you look at the data amongst Latinos, you see 8% of the cases were Latino, whereas 14% of the folks in that data set were Latino. And I'm wondering again if there's some undercounting here, but it's something to pay attention to as we move forward and get additional data. But this is what was out at the time, and certainly it indicates that there are disparities, particularly amongst within Black populations, but the data is just not, it's not as high quality as we would like it to be, obviously. So it's interesting, at this time where we had limited data that was coming from the CDC and all this missing data from the jurisdictions, and then there were a lot of jurisdictions or states that were not releasing their data, the media outlets said, you know what, we're going to create data. I mean, they basically went about analyzing data on their own to determine whether or not there were true racial and ethnic disparities. So this is actually the Washington Post. So what they did here was they did a county level analysis, and they aggregated the counties by the percent population. So I'll just read it right across. So they took 131 counties that were predominantly Black. And what they found was that the number of cases across those 131 counties is 137.5 per 100,000 population. And then the number of deaths was 6.3 per 100,000 population. So they compared that to the white counties, the counties that had predominantly white populations. That was 2,879 counties. The number of cases per 100,000 population was 39.8, and the number of deaths 1.1. And the storyline is that the Black counties had 6 times the rate of deaths versus the majority white counties. Now, again, I think that we know that there are racial ethnic disparities. I don't know if this is the type of data that would necessarily be publicized, but I think that, again, it's this issue of wanting to know what's happening, wanting to act on something. And if you look at some of the commentaries and opinion pieces that came out during that time period, certainly people were quoting this data quite frequently. So I think this headline speaks to what's happening here. Okay, so we know that there are these disparities, but they could be even worse than we think based on the fact that we have a lot of missing data. Okay, so I think that's really the takeaway point here, is that we have some striking data, but it could be even worse. We only have 41 states that are reporting cases by race and ethnicity. 38 states are reporting deaths by race and ethnicity. We haven't even really talked about testing. And as you all are quite well aware, there was quite a bit of rumbling, advocacy, dismay about the lack of accessibility of testing during the first few weeks of the epidemic, and even still now, people not having access to testing. And so there are only 2 states that are reporting COVID-19 testing by race and ethnicity, Illinois and Kansas. And I did look at the Illinois data, and again, a lot of data is missing in terms of race and ethnicity. So I keep wanting to just hitting this point home hard, because I think that it's going to speak to the responses that come out of this as to whether or not or how good our data was or is. or will be if it's going to be fixed. So a lot of missing or unknown data by race and ethnicity. And then those of you who work with big data sets know that issues like social determinants of health, they're just not here. I mean, we're making some guesstimates about what's happening based on, like I said, the neighborhoods and what we know about those neighborhoods, or testing, or in particular populations, like there was testing that was done in one of the homeless shelters, or testing among specific populations. And then particularly within Boston, where we know we have a lot of non-US born individuals, we don't have region or country of origin data. And I think that that's unfortunate too, because you want to do targeted responses, and I just wish that we've been more prepared. I'm sure we are all saying, in hindsight, you want things to be more clear. But I think the other thing too that came out in the this opinion piece that the Washington Post wrote was that we can't wait for more data, better data, the best data. We really need to be acting now and acting decisively to address disparities. So following the release of these data, there was quite a bit of media attention that was focused, and is still focused, on racial and ethnic disparities and what the underlying drivers are. So most of that talk I found was focused in on sort of proximal issues, proximal drivers of these disparities. So this issue of essential workers and low-wage jobs, and the fact that Black and Latino workers have less ability to stay home, less ability to do physical distancing. I think that's great. I think it's important to understand those dynamics, and I'm going to show a model that'll demonstrate some of that stuff, but I think we really have to get to the deeper issues, the root causes. So some journals, media outlets talk about inequality, some talk about biases, but I think what really surprised me, honestly, and I think it was very important, is that there were a number of headlines that really did hit it on the head. They were talking about inequity. And that's not always really something that people talk about. They were talking about the pathology of racism. They were talking about defeating COVID-19 by confronting racism. I was actually surprised. There was a tab about COVID-19 and racism on the Boston Globe, front page. So I think that's what we need to be doing. We need to be having more honest, open conversations about the nature of our country, the nature of our world, but specifically as it relates to this talk, the nature of our country. So I think it's helpful to frame and define issues as we talk about solutions. So structural inequity, we're talking about systemic disadvantage of one group versus others, and that could be by race, ethnicity, sexual orientation, whatever. It's not specific. Unequal allocation of power and resources, which manifests itself as disproportionate social, economic, and environmental conditions. So that's a general sort of term for imbalance of power for the most part. Structural racism, that's really hitting it on the head again. It's the totality of ways, historical and contemporary. I talk about contemporary issues more frequently, just because I think that there's a tendency to think about what's in the past and not realizing that we're living in the moment. We're living in spaces that are rife with these sort of hierarchies. And these totality of ways have reinforced a system of hierarchy, privilege, and power that really excludes people of color. And the way that I look at this is that structural inequity and structural racism, they manifest themselves through structural factors, okay? And again, I like formatting things so you really understand what's happening. That way you can decisively develop interventions. You can really figure out what needs to happen. And so, there are a lot of people who've done work looking at how factors such as the three that I just selected, there are many others, impact health. Okay, so David Williams at the Harvard School of Public Health, certainly Paul Farmer, and others have really made, critical, have added, critical information to our understanding of how this happens. But just to talk about them a little bit as we move forward and look at how we approach solutions. We were talking about housing status. I think much has been said about homelessness and what's happening in homeless shelters, and I think that's very important. But I think less has been talked about in terms of residential segregation, which is largely a result of past federal housing policies and sort of the current ramifications of those policies. Redlining, which is a system of racial discrimination in mortgage lending, which stopped particularly Black people from home ownership, which is a major source of building wealth in our world, in our country in particular. And I think that if you look at the data analyzing those communities that were redlined throughout the 60s and into the 70s, you see that those areas are still, undesirable. I mean, quite frankly, there's overcrowding, there's public housing projects, there's poor access to services, there's food deserts, just many things that we know have an adverse effect on health outcomes, and things in terms of the overcrowding, in terms of the poor access to services or poor quality health systems, we know increased risk for COVID-19. And what about mass incarceration? So, sorry about that. What about mass incarceration? So in the U.S., we know that there are more than 2 million people who are incarcerated. The lifetime risk of incarceration for Black men is 1 in 3, for Latino men it's 1 in 6, and for white men it's 1 in 17. I think that understanding why that is the case is important. It can be traced back to the war on drugs and differential sentencing for Black and Latino men in particular, for crack cocaine possession and for distribution as opposed to powder cocaine. A lot of people talk about clouding within prisons, and certainly I know a lot of people at MGH are advocating in terms of immigration detention centers, because we're talking about the same thing. We're talking about crowding and being in close quarters. But I think fewer people know, or at least maybe have thought about the fact that incarcerated populations are more likely to have chronic health problems like diabetes, high blood pressure, and HIV than other folks. They just are, and then they have poor quality health systems within prisons in some cases. So some prisons are doing quite well. So I think understanding those dynamics and how that may play a role in terms of COVID-19 risk and the risk of disparities in general is very important. Lastly, I had this one picture. You've probably seen something like this before in the news media of folks who are essential workers wearing masks on this crowded public transportation. So those two issues that I already talked about, they lend themselves to limited opportunities. If you're living in a racially segregated, lower income, resource limited setting, you're going to have fewer opportunities. You're going to be subject to public education that may or may not be, that in most cases is not up to par. If you're incarcerated, you're going to have a difficult time getting a job. So all of these factors, if you just think about the historical nature of them and the fact and how they impact people's lives, that's what we're talking about when we're talking about structural factors and the impact that they have on COVID-19 risk, as well as risk of other infections. So I just want to show you this sort of mechanistic model, so it's just very clear how this works. So some researchers put together this model, and they did it for the purposes of understanding pandemic influenza. They didn't do it for COVID-19. It's 2008, and then there was an adaptation in 2012. So what they looked at first was, what are the sort of distal issues, the distal barriers to avoiding risk? So access to clean water, if there's limited access because you're incarcerated, if sanitation isn't that great, or you're homeless, population structure overcrowding, we talked about that, low wage employment. I'll talk about racial profiling in a second. But these are things that will stop people from engaging in harm reduction behavior. So the proximal issues, the hand washing behavior, the physical distancing, and then the wearing masks piece. I'm sure you all heard in the media about racial profiling, Black and brown men wearing masks, even hospital surgical masks, as opposed to like bandanas, and being told to leave places, being arrested or at least handcuffed in some cases. So they would feel uncomfortable wearing masks in those circumstances. And this lends itself to differential exposure, which then lends itself to disproportionate rates of infection and death. So on the other side of the coin, there's differential disease susceptibility, okay? And I think we've talked about this, the media's talked about this a lot, it's been out there. Healthcare access, when you're thinking about, of course, financial access is one thing, but if you're talking about like quality healthcare, talking about culturally appropriate healthcare, non-discriminatory healthcare, issues about psychological health. So there's growing data, there's a growing body of literature that
Sorry, not sure what happened there.
Hello?
Got you back.
You're back. Sorry about that.
Oh, okay. Was I off? Should I restart what I'm saying, or? I'm not sure when I was cut off.
We just lost you.
Oh, okay. Okay.
For like a second. You're good. You just got to reshare the screen.
Okay.
Reshare your screen.
Oh, okay. Reshare my screen.
So you were talking about disease susceptibility and severity.
Yeah, I think I'm on. I should be on sharing. You can't see it?
Yep, you're sharing now, and we can see your desktop.
Okay. All right, I hope I didn't do that. I'm sorry if I did something. Okay, so talking about differential disease susceptibility and severity. So healthcare access, I'm not just talking about financial access, but access to quality healthcare where that's culturally appropriate, that's non-discriminatory, I think is very important. There's a growing evidence, a growing body of literature talking about psychological health in the setting of a country or environment where there is the presence of racism. So there are self-reported measures of racism out there, and that may impact psychological health, and that has been associated with preclinical indicators of disease like inflammatory markers, what's called allostatic load, or the stress on the body and the brain from being worried or concerned about racism or any sort of threat per se, coronary artery calcification and dysregulation. So I have a bunch of articles that talk about that more because I think it's a burgeoning area of research and literature. And there's a really good article by David Williams from 2019 that talks about it. And then there's the issue of medical and research mistrust. And I do some work in that area, and I think it's an important area for us to look into because if you look at issues of healthcare access, why people do or don't access healthcare, they do or don't. Oftentimes, it's because they don't trust the healthcare system. They may often trust their doctor. They may have a good individual relationship, but the overall system, the overall institution, they may have problems with. So all three of those issues can cause problems in terms of chronic diseases. But then I have, vaccine behavior, and I circled that with some dotted lines. And obviously, we don't have a vaccine for COVID-19, but these issues of medical mistrust and healthcare access will contribute to whether or not people will actually take the vaccine once it's available to the public. Interestingly, there's already buzz, as you all may have seen in social media, about people not wanting to take a prospective COVID-19 vaccine. These are real concerns, particularly as we're talking about clinical trials and whether or not people will participate in clinical trials, both for vaccines as well as from treatment. So all of this leading to differential disease susceptibility and severity, and differential disease acquisition and death. So I think it's all very important. And this is just the whole model together, so we can get past this. And I just wanted to, emphasize the point, because I know we all talk about it in the media about differences in some of these underlying predictors of severity of COVID-19, like obesity. But here's the data. I mean, this is one of the more recent resources, which shows that Black and Hispanic women in particular have a higher rate of obesity than white or Asian individuals. And then on the right, I'm showing you data in regards to diabetes, and the prevalence of diabetes is highest in Native American and Alaskan Native populations, which I haven't really talked about much because I don't have a lot of data on Navajo Nation and what's going on. But as you see, there's also high rates of diabetes in Hispanic and Black populations, and I think we're all sort of familiar with that. The flu vaccine uptake information I added here because, again, I think it lends itself to the idea that there are going to be some disparities in terms of vaccine utilization. When the vaccine does come out, I can predict that now, and preparing in advance, coming up with some interventions that will increase or at least ensure equitable uptake is going to be really important. You see non-Hispanic Blacks and Hispanic individuals have always really had lower uptake of the influenza vaccine. Okay, so let's go back to mistrust, because I really think that's an important piece that we as healthcare providers maybe can do something about. So mistrust is born of structural inequity. That it's being in a system or living in a system, living in a world where you see yourself surrounded by sort of social inequality, and you see bad things being done to people who look like you. I mean, it's just a natural human response. There are all sorts of different types of mistrust. As I alluded to previously, there's healthcare provider level mistrust. You may not trust your clinic. You may not trust research and not want to sign up to be involved in a clinical trial. There may be systems level mistrust. And I've done some work looking at HIV-related mistrust. Now, what that means is holding certain beliefs regarding HIV, like conspiracy theories, essentially. I think people who do this work don't really want to call it conspiracy theories because it makes it sound it makes it sound apocryphal. It makes it sound like it's, something ridiculous. But really, a lot of people hold these beliefs that HIV was created in a lab. This isn't something from way back when. This is actually current information. So the question is, and I think the answer is obvious, is there going to be COVID-19 related mistrust? I mean, it's already there. It's in social media. People are talking about it. It really just hasn't been measured. And that's one of the things that I'm working on with a few folks who I work with, because I think that it's going to be related to whether or not people will utilize the vaccine, will take the vaccine, as well as whether or not they'll get care and take treatment, going forward as it's made available. So issues of mistrust higher amongst Black and Latinx individuals, which is not surprising. And then particularly looking at HIV, because I said I was going to talk about parallels. Medical mistrust has been associated, as well as these conspiracy theories associated with HIV risk, lower antiretroviral therapy adherence, lower uptake of HIV testing, and some people test more if they don't trust the system, as well as uptake of pre-exposure prophylaxis. So I'm actually going to skip this slide just because I'm looking at the time, and I know that we want to end reasonably. So I'm just going to skip past this, so this is interesting, and get to the points of other parallels with HIV. So this is most recent data on HIV related to disparities. They're totally across the U.S. each year. There are about 37,000. It's going down a little bit, 37,000 new HIV infections per year. In terms of racial and ethnic disparities, similar striking disparities. When I talked about being shocked, some people were shocked when they saw things related to COVID-19. Those of us who do HIV-related stuff, we weren't as shocked. We were dismayed. It was a sense of deja vu, but I don't know that we were shocked necessarily. So HIV incidence is 8 times higher amongst Black or African American individuals, and 3 times higher amongst Hispanic, Latin, or Latinx individuals than it is amongst their white counterparts, and certainly lots of disparities by risk also. So there's currently this federal initiative to end the HIV epidemic. So the idea is that we have the tools, we have the political will, we have testing, we have all the things, that, we'd love to have also for like COVID-19. But the issue is that there really needs to be a concerted effort to move that forward and to overcome disparities. So, this particular study, I'm just going to talk through really quickly, because basically what it's answering is, will we really end the HIV epidemic in the United States? And if we don't end it, then why? So in this study, they basically did modeling. They put together all the different interventions and different combinations in 6 different cities, because like with any other infection, each city has its own sort of microepidemic. So you may want a different combination of interventions per city that you're in. And what they found is that even with the ideal implementation, even with the ideal input, none of these cities actually gets to 0. None of these cities actually end their HIV epidemic. And when you read the discussion, and this was actually presented at a recent conference, I really like how they framed it, because basically what they said was that unless you can do all you want in terms of interventions, in terms of sort of dealing with these sort of proximal issues, the things that giving people PrEP, testing everybody, people wearing condoms, whatever. But if you're not dealing with the structural issues, if you're not dealing with the root causes that I framed when I was looking at both, COVID-19, and we'll talk about it with HIV, if you're not dealing with those root causes, then you're never going to really truly end something. Okay, because there are a lot of things, complex things that are happening that are driving epidemics forward. So if you look at locally at our HIV rate in Boston, I think it's interesting to look at this data, and I'll show you why I think it's interesting. In the dark blue, you basically have the neighborhoods where you have the highest rate of HIV infection across the city. And we're talking about Mattapan, Dorchester, Roxbury, as well as East Boston and South Bend. So put that next to the map that we just saw previously, looking at COVID-19 infection rates, and you see we're really talking about a lot of the same neighborhoods. And why is that? I think the reason is it's kind of obvious. I mean, there are a lot of these structural factors, a lot of these issues that we're talking about that relate to both, and that put people at risk for both infections. So when you're thinking about parallels, a lot of it has to do with the underlying drivers of infection. And so in terms of like looking at actual conceptual models or framing, like I talked about with COVID-19, we could look at these same 3 structural factors that I talked about before: housing status, incarceration, and I think before I said economic opportunities, but low socioeconomic status is the same difference. So similar structural factors, but just different mechanisms. Well, sort of different mechanisms, because part of it is this issue of healthcare access and having limited healthcare access, which puts you at risk for pretty much everything. But here I give some examples. But also with HIV, you're having higher risk exposures, and exposure is certainly an issue with COVID-19, but this is different, obviously. Higher risk partners, altered norms and beliefs. If you're living in circumstances like in prison or jail, in terms of behavior, low socioeconomic status, so engagement in transactional sex. And then this issue of psychological health. So I talked about exposure to chronic stress. So I mentioned this exposure to chronic stress can increase your risk because you have more inflammatory markers, cortisol, all this allostatic load stuff. Here, chronic stress actually increases the risk of engagement in higher risk behaviors, so substance use and high risk sexual behaviors. So a lot of the same factors at play as we think about these two different infections. Another parallel that I think is important to mention was articulated very well in the New York Times during that first week when we got that, the increase in data, the deluge of data, actually, the missing data, as well as some, racial and ethnic data from a bunch of different states and jurisdictions. Interestingly, a lot of people who are living with HIV, and this is coming from a lot of my patients, sort of felt a sense of deja vu, similar to the deja vu that I was telling you about with in terms of the disparities. And the way that many of them talk about it is, well, this feels like the beginning of the HIV epidemic, where there was slow and inadequate government response. And a lot of people, for those who are Black or Latino, said, well, nobody's paying attention to the fact that there increased risk, increased numbers in our communities, and it took an overwhelming amount of advocacy to get people to pay attention. And then the discrimination that people are facing, and that certainly people are facing, and I'm going to tell you a quick patient story next. And then this issue of stigma. And we've certainly seen, if we don't, have it in our own lives, but amongst our patients or colleagues, stigma facing certain groups of people, particularly amongst Asian individuals living in the U.S., but also amongst other folks. I'm just going to share this one story because I think it really spoke to a lot of these issues, this stigma on multiple levels, and that's what I mean by intersectional. So there was a 38-year-old patient who was referred to me by a community-based organization. He was from Uganda, lives outside of Boston. He has limited English proficiency, and he came to the U.S. about 4 years ago, and he works as a CNA. And I don't know anything about, I didn't ask him anything about his immigration status. He rents a bedroom in an apartment from a Ugandan couple who has a child. There's another man who lives in the house, rents another space in the home. And the child of the couple who, is sort of running the apartment for the most part, was recently ill with a cough, and that resolved pretty quickly. About a month ago now, it's been quite a while since I was first introduced to him, he woke up with a cough and chills. And that day that he woke up, somebody heard him cough and told the couple, whoever was in the house, and they told him to pack and leave, and he left. He was really afraid to access care. He eventually got referred to me because there's this network of African immigrant community-based organizations out there, and they set up a hotline, and somebody told him about the hotline. I think he stayed in a church one night, and somebody connected him with the hotline. And we ended up, they then connected to me, and we ended up getting him tested. He was very afraid to access care, and for I think a number of different reasons, but also because with limited English proficiency, he was afraid that, given the language that he speaks, there'd be nobody there who was going to speak his language. So we sent him with a community health worker. He ended up being housed by that organization, and he did well clinically. But unfortunately, he was homeless until the organization stepped back in to sort of negotiate his living situation. I tell this story because I think what I want to do is switch to sustainable solutions. I know we're running short of time. Do I have time to go through, Karen? Okay.
Yeah, it's going to be great.
Okay. So I put in the title Sustainable Solutions because, again, I think we need to sort of get past the emergency portion of this epidemic. Certainly, we're not there yet. But my sense from talking to a lot of people out there who do, racial and ethnic disparity work is that they really want this to be a bellwether moment. So Clyde Yancey is the chief of cardiology for Northwestern. He's sort of a leader in disparities work, and is in a lot of the national organizations. And he wrote a opinion piece in JAMA. And I think what he said really resonated with a lot of people, because he was basically saying that, we've been doing a whole lot of stuff about disparities. We've been talking about it since the Heckler report back in '85, and then the Institute of Medicine report in, 2002 or something. And people are doing things, people are trying, people are, have efforts that they're moving forward. But really, there needed to be something to push people to the edge. There needed to be something, and maybe COVID-19 is that something. Maybe it's time that we do something different, and maybe this is what's telling us that we need to do something different. So I think, when I think about doing something different, it's not that I think that the actions are necessarily different, I think that part of it is the effort, the redoubling of efforts to do things in a way that is truly going to end up being meaningful and sustainable. So Valerie Stone, who's the vice chair of the medicine department, she does work with diversity and inclusion over at Brigham Women's Hospital. She and I wrote, we're co-editing a book. It's on HIV and communities of color, and we wrote this paper about achieving health equity within HIV. So it had this pre-COVID-19. The book is coming out later this year, but the reason why I bring it up is we talked about some specific actions that we think need to happen if we ever really want to end the HIV epidemic. Now, a lot of people talk about, or at least I've heard it more often, talking about moving from cultural competency to structural competency, to really be having these conversations that we're having this morning about the history of our country and how it impacts people, how it impacts people's risk, how it continues to impact people's lives through generations, and what does that mean, and how does that shift our lens in terms of how we view patients. And I think that there's a movement towards this, but it's not that, I think it's going to take a lot of effort, to be quite honest with you. I mean, and even if it's taught, making that shift, realizing that there's privilege and power, many of us, including myself, benefit from those being in those privileged spaces, whereas other people don't have that benefit. And there needs to be some, some way to compensate for that. We need to operationalize that within how we interact with our patients, conveying that understanding to our patients, as well as advocacy and leadership. I know a lot of you all do advocacy and leadership, and I think that, there's probably no lack in that necessarily, but it's what we're advocating and leading for, and I think that brings me to the next slide where, so I wanted to talk about the second area of bullets, because I talked about this community-based organization with Adaptation that I mentioned, and how they are doing things for themselves. I mean, they're on big, GoFundMe, people give them, $50 here, $100 there, whatever. They sort of set up this whole thing to take care of their community. It wasn't something where, they waited for anything to happen, or, I'm sure they would love to get some big grant or whatever, but, it's advocating to uplift those types of community responses, because quite frankly, I think those are the responses that are going to be sustainable. Just quite frankly, I feel like that's what's going to last within places beyond the emergency, actually understanding, who are the leaders of what's happening? Where do those ideas come from, and how do they get mobilized among people and within people, within individuals in their own communities? And then I would also say, the top half of the slide, I think a lot of work has been done looking at patient interactions and how we interact with our patients. I think that for many people, coming within the healthcare system, thinking about interacting with doctors who don't look like them in most cases, who don't speak like them in some cases, is very daunting. And even if they do, it can be a negative interaction, and then issues like mistrust are bred within those interactions. I think a lot of work needs to be done here. I'm working with one of my mentors on looking at, different types of interventions for physicians and other healthcare providers. So to really engage patients in a way that breeds trust, because to me that's the key thing that's oftentimes missing in the patient interaction. And then, of course, diversifying the workforce at all levels. I mean, I don't think I need to say anything more about that. I mean, a lot of people are working in that regard, and I don't want to undermine their efforts, but I think a lot of people are doing it. It's just about redoubling that effort. I think that's really what I wanted to say there. So in conclusion, we have these striking racial and ethnic disparities that have been noted thus far in terms of the pandemic. Much of the racial ethnic data are missing. Therefore, we don't know the magnitude of the disparities, and certainly, I'm not sure if we're ever really going to totally know the magnitude, given how much was missing up front. And I don't know that there's enough of an effort that's going on to make sure that there's better data is being collected. I talked about structural inequity and racism driving COVID-19 infection, as is the case with the HIV epidemic. And then I think that thinking about how do we address these issues beyond this immediate emergency to really create a sustainable movement towards sort of, I guess, finally addressing racial and ethnic disparities, and not to say again that things haven't been done and that things haven't gotten better in some respects, but like I mentioned in the quote from the JAMA article, this could and should be a moment in time where this is the time to really change, and to make things last and to really make a difference, and that could be what we're living right now. So with that, I'll stop there. I don't know if we have time for discussion or thoughts, but hopefully we do.
Thanks so much, Dr. Ojikutu. That was really, really appreciate you sharing your expertise and experience and taking the lens of your experience and research with the HIV to the COVID pandemic. If you're all right, hanging out for maybe 5 or 10 more minutes just to answer some of the questions that folks will put in the question box, that would be wonderful.
Sure. Mm-hmm.
One of the things that I was thinking of, just to start the questions off, and I know there's one already in there as well, is just thinking about your experience with HIV and specifically with mistrust. Have you seen any successful models for how to address medical mistrust? That seems like a huge part of this would be that. And I would love to hear from your experience what has been successful, and maybe some of that was in those last slides.
Right. So it's a problem, to be quite frank with you. And I've had a lot of discussions with folks even recently about how to address mistrust. There aren't a lot of good interventions. I mean, that's just being frank. People have done things with that are directed at patients. So like motivational interviewing with patients to get them to see the healthcare system in a different light. I don't know if that's really sustainable, and I don't even know if that's the direction we need to go in. I actually think that there's something that needs to be done within us as healthcare providers, and I think that the intervention needs to be directed at us, quite frankly. And that's what we're talking about now in terms of like developing a curriculum that brings in some of the structural competency stuff, but kind of putting yourself in the patient's shoes. I think that's part of it too, is us understanding really where people come from, because I don't think we do. And when I say that I really do mean, and that's, I don't think it necessarily has to do with race per se. It's who we are and where we are in life, and differences in socioeconomic status and in class within our society or whatever. I think that there's a lot that needs to be overcome in breaking down walls during the patient interaction. So yeah, it's definitely an area where there's work that needs to be done.
That's great. To look at the Q&A in the chat box, someone sort of built off of that a little bit, looking globally, and asked, can you talk about the possible drivers for global disparities, particularly related to African countries and attitudes, mistrust, misconceptions towards COVID-19?
Yeah. So, I think it's interesting. I think a lot of what we're seeing about mistrust is something that's not just domestic. I've, worked internationally, and therefore I've had a lot of conversations about these issues of people from other places, kind of flying in and doing things and leaving things behind, but not really knowing what the people wanted in the first place, or not engaging them in any sort of meaningful way. And that's, again, me just being frank and, sharing that I think that the way that we engage people, it needs to be looked at critically. I think if we want to do things that are truly sustainable for, on behalf of people, or, to change the way that, healthcare is accessed, the way outcomes turn out at the end of the day, I think we have to be doing this in true partnerships. We have to let other people lead. And I think even the way that our system of development and developmental assistance is set up, it's not set up that way. It's not even set up in many cases where we have, funding that's going directly to partners in the developing world. It's going through a conduit, an intermediary, And I say this and laugh because I've done that sort of work. So I know, and I think it's good to do that kind of work, to understand how things really operate, to understand why we continue to have the same sort of problems, because we're not truly engaging on an equal footing, on an equal level with the folks who we're supposed to be trying to help, and that's. I shouldn't say that's writ large. I mean, I'm not making a general statement. I'm saying that's a trend that we need to keep our eyes on as we do our work, as we're writing our grants, as we're thinking about who to engage and how to approach research questions. How do we truly work in partnership with people, and what does that partnership? What does that really look like?
I really appreciate that. I love that, sort of to pull out your responses there. I love that you started with the idea of looking at ourselves. And I think I work a lot in medical education and thinking about how do we train the next generation to maybe do that much better than we have. And the idea of partnership, both individually with an individual patient, the shared decision-making model that you presented, but then also thinking about that at the community level as well, when it's organization to organization. And I think those go hand in hand, individual by individual, and also at the organizational level.
Absolutely.
So I really appreciate you sharing your expertise and bringing this all together in a way. I think we've all seen bits and pieces of it. I think I really appreciate how you brought it all together and then built onto that with the framework from your experience with HIV. So thank you so much for sharing your expertise with us this morning. Sorry to everyone and Dr. Ojikutu about the technical difficulties. But we appreciate you guys sticking with us. And I know Carrie posted up the information on how to apply for the CME credits if that is applicable to you. And we thank everyone for joining us this month, and we look forward to seeing you next month. So thank you so much, Dr. Ojikutu.
Thank you for having me.
Bye.
Bye.